We're really pleased to have everyone in today's session. Really excited to hear the legislative update from Michelle. I know there's, excuse me, a lot going on. And, we're beginning the legislative sessions in most of the states, and Congress is continuing and continuing to work. And there's been some interesting developments when it comes to legislation related to telehealth. So I'll pass off to Rochelle. And at the end, I think Christy's going to remind everybody, and I'll remind everybody at the beginning, if you haven't re-signed up for the series, we're asking everybody to re-sign up in 2022, just so we can make sure we have a good list of those who are still interested in participating. So Rochelle, I'll let you go ahead and get started.
All right, very good. So we've kind of been talking about in the last couple of sessions how, March through May or June of 2020, we saw a lot of activity in terms of waivers, flexibilities, the federal public health emergency declaration and state emergency declaration orders that increased a lot of flexibility for telehealth in terms of licensure of providers, originating site, distant site providers, flexibilities in the Medicaid programs. Then things were relatively quiet for a while, other than some changes in the annual program updates for Medicare. So now, as states at their state level are kind of winding down or have wound down some of their state emergency declarations, we're starting to have to repiece together how that connects to the federal public health emergency, what Medicare is allowing versus what states are allowing. And we're starting to see some legislation that has the potential to make some of those flexibilities permanent in various ways. So that's what we're going to talk about today, the status of some of the federal as well as the state bills and legislation and what's happening to hopefully make some of these flexibilities permanent. Probably won't get to payer specific policies today, but if we do, I'll talk about a few of those. I want to focus in particular on several really key federal and state pieces of legislation to update everyone on. So one of the most important pieces in January, we kind of all had our eyes on January 14th as a key date where the federal public health emergency was set to expire, and they go for 90-day periods. So it can be renewed every 90 days as it has been since it went into effect in, I guess it would have been I think it was January of 2020 when the federal public health emergency, before we got some of the Medicare flexibilities in March of 2020. So that takes us into April of 2022, mid-April of 2022, when we may see a renewal or expiration. I think we'll start to see in the next 3 to 4 weeks, if we don't have an indication from the Secretary of Health and Human Services at a federal level, that there's a sign or an indication that it may be allowed to expire April 14th. That may be a good indication that we may be facing another 90-day extension that would take us into the summer. And I say that because while it's not binding, there was a letter from the Secretary of Health and Human Services to all of the 50 state governors last year, I believe it was, indicating that the secretary intended to give 60 days notice before the federal public health emergency would expire. At that time, when that memo was sent out, many of the states still had their emergency declarations in place. So the intent was to communicate to the states, so maybe there could be an alignment of when those emergency statuses expired or withdrawn, or allowed the states to kind of adjust to the end of the federal public health emergency. What we've seen, however, is many states, and the 3 states we're focused on here, Kansas, Missouri, and Oklahoma, have already rescinded, withdrawn, or allowed their state emergency statuses to expire. So what we're left with right now is the federal public health emergency, with some asterisks at the state level that I'll talk about in just a little bit. So One of the key things that we're looking at the federal level is that with the Medicare program and the flexibilities around telehealth that we have during the public health emergency, there are a couple of key dates that we're watching, and then a couple of key pieces of federal legislation that we're watching. And the key dates are the end of the public health emergency, because there are certain telehealth services that will no longer be available as telehealth under the Medicare program the day that the public health emergency goes away. So that's why that 60-day notice that we hope we get from the Secretary of Health and Human Services at the federal level is so important, because that's going to give us some advanced notice and preparation for those particular services that will no longer be available as telehealth after the public health emergency goes away. Another key part of the date that the federal public health emergency goes away is that some services that will continue to be allowed as telehealth services for a temporary period of time, even when the PHE ends, may be allowed by audio only, but only until the federal public health emergency ends, at which time they may continue to be covered on a temporary basis as telehealth services, but only through December 31st of 2023, or at least that's the date that we're currently operating under with the Medicare rule that went into effect this year. So that the second important date then is December 31st of 2023. We had in the final rule, Medicare's rule for 2022, Medicare decided that a lot of these telehealth services that were added during the public health emergency, and that they have fallen into a brand new category called Category 3, or temporarily covered telehealth services, will continue to be covered through December 31st, 2023, even if the public health emergency ends sooner. So even if the PHE at the federal level ends April of this year, we will continue to be able to provide certain telehealth services through December 31st, 2023. Now, which services are available until the end of the PHE versus December 31st, 2023 are outlined in a spreadsheet in the CMS final rule. So if you want to access that and get an idea of the services that you provide and which of those key dates you need to be particularly aware of, you go to the CMS website, cms.gov. You click on Medicare, you scroll down and click on a link for physicians, and then you can go to the physician fee schedule regulations and notices link and pull up the 2022 final rule, and there will be an attachment for the telehealth list, and it's an Excel file that shows you by CPT code whether it is a permanent telehealth service. So regardless of what happens with the PHE, you can deliver that particular service by telehealth, whether it will end when the public health emergency ends or whether it will end December 31st, 2023. So when the public health emergency ends, a couple of key things that we're going to have to watch for is at that time, the flexibilities to allow the patient's home as an eligible originating site will go away, because that is set by definition in the Social Security Act. And so the Medicare, the Department of Health and Human Services, doesn't have the flexibility outside the public health emergency to change that, with very few exceptions. The other thing that's going to be important in terms of what we will revert back to the day the public health emergency ends are the definitions of originating sites and distant site practitioners. So therapy providers, PT, OT, speech therapy, that are not part of that definition of eligible distant site providers under the Medicare program outside of the public health emergency or prior to the public health emergency, that are only as a result of waivers and flexibilities that are allowed due to the public health emergency declaration, will also go away at a federal level for participation in the Medicare program. That's not necessarily true for states and state laws and state Medicaid programs. So unless we have literally an act of Congress at the federal level to change some of those definitions of originating site and eligible distant site practitioners, we may have a lot of inconsistencies to work through between what states allow, what Medicaid programs allow, what private payers allow, versus what Medicare will pay for under the provisions of the Social Security Act. So the good news is where we've got a little bit of time, we know at least a couple of months until the public health emergency ends. I think likely several months and into the summer, if not longer. And for some services through December 31st, 2023, that gives us a little bit of time to hopefully have an act of Congress to change some of those provisions and restrictions within the Social Security Act. So I want to take a look at some of the bills that are out there right now at a federal level and kind of give you an idea of what the activity is or has been surrounding these bills and telehealth services, so we can see some of the themes on what we might see in terms of telehealth change on a permanent level. As of right now, though, there has not been federal legislation enacted that actually changes any of the pre-COVID telehealth rules for Medicare in terms of originating site and distant site practitioners. So a couple of those at the federal level, they all have different names and they all have a slightly different focus. Some are focused on rural health providers, particularly FQHCs and RHCs. Some are focused on access to mental and behavioral health services, and others are focused on just telehealth in general. So the Ensuring Telehealth Expansion Act is one that is focused on rural healthcare providers, and it would make permanent the flexibility that we've seen during the public health emergency that makes FQHCs and RHCs eligible distant site professionals for telehealth services. Even before the public health emergency, FQHCs and RHCs can be eligible originating sites because they tend to be in, and by their definition, RHCs are in rural health areas that would meet the rural health geographic requirements as eligible originating sites under our typical Medicare rules. But we're not eligible distant site professionals because I think the intent and the design or the common practice was often that the patient was coming into the RHC or the FQHC as an originating site and receiving a distant site professional telehealth service from, KU or from a University of Missouri or a healthcare provider or facility in another area. But we're seeing more and more that those RHCs or FQHCs can employ or contract with healthcare providers or even use their own providers to render telehealth to patients who are at home. So it could be an RHC provider serving as the distant site professional, seeing a patient at home. We reduce exposure in the clinic and we free up the clinic time for patients who maybe telehealth would not be an appropriate or an available modality. So this act would make that a permanent change. Yes, go ahead, Christy.
We had a question in the chat from a few minutes ago asking if a link to that could be provided. I believe it might have been when you were walking through the website and telling where to click, but Dr. Nickel, if you want to clarify what link you were asking for, we can make sure we get that for you.
Could a link to that? Okay, so Dr. Nickel, is that referring to the link for the Excel file, the list of telehealth services? You can watch that in the chat. I can absolutely send that as part of when I send the final slides that we send out. That's no problem.
Great, thank you.
Yeah, absolutely. So we've got RHCs, FQHCs. Would, if this act were passed or something like this act were passed, would be permanently eligible to be distant site professionals. It does several other things, eliminating many program payment policies, say that 3 times fast, that we see in dialysis centers, hospice, home health agencies have as part of the initiating of the services certification for the need for services in those programs, an initial face-to-face visit requirement, in person, I should say, requirement. And so a lot of these pieces of legislation would also make that available via telehealth rather than requiring a physically in-person visit to meet those requirements. So this act would clarify that for dialysis patients and providers, that could be done via telehealth, hospice certification and recertification. And the interesting thing in this act is that what we see in a lot of pieces of legislation is making permanent during the public health emergency. We've created home as an eligible originating site. That has created a lot of question around patients that are not necessarily in a healthcare facility, but they're also not at home. I kind of use the example of the Starbucks, the library, the grocery store, in a parking lot, you name it, but a place where they're receiving a telehealth service, not in a healthcare location, but not exactly at their home either. And so what this would do, instead of making home a permanent part of the definition of originating site, it would simply say originating site just means where the patient is located. And so it kind of removes that question of whether the patient site does it technically qualify as home to be able to be an eligible originating site, even with the public health emergencies. So good news and bad news, this has some really cool provisions in it. Bad news is it was introduced in January of 2021, but it really hasn't had any significant activity since that time. The CONNECT Act for 2019. Now, Dr. Nickel, if you were referring to links to these acts, I noticed on the previous one, I didn't link to it. I'll add that before I send the slides out. The rest of these do have links, so you can actually go read the text of the bill if that's what you're looking for also. So this act, it's 2019, so that suggests to me this particular piece of proposed legislation is not very likely to actually be enacted. But a couple of interesting things about it was that it was bipartisan, so it had the support of both parties. It would give the Department of Health and Human Services a clearer ability to waive a lot of the telehealth requirements, as long as it would not deny or limit coverage to individuals, and doing so wouldn't be expected to compromise quality or significantly increase costs as part of those waivers or flexibilities. This one has a really important provision that we didn't see in the previous act that would also waive any geographic restrictions. Because remember, prior to the COVID public health emergency for Medicare, the originating site where the patient was receiving the service not only had to be an eligible healthcare location with certain exceptions where the patient could be at home, certain very narrow exceptions, but also had to be in a rural geographic area. And there's a very specific definition of what it means to be rural. I'll just kind of use that for purposes of this presentation. So, you know, in metropolitan areas, the Johnson County, the KU Med Center, telehealth generally was not available under the Medicare program. And that's really a component that of telehealth transformation and policy that's being examined for after the public health emergency. So this act would have done that, would have eliminated that geographic requirement for all Medicare telehealth services. It would permanently add the home as an eligible originating site for mental telehealth. Now, while this particular bill doesn't appear to be likely to make any progress, we have seen on a permanent basis the home made an eligible originating site for certain telehealth services. So we've got that flexibility during the public health emergency. We already pre-COVID had the ability to provide certain telehealth services to individuals at home by Medicare when we were treating, evaluating, diagnosing substance use disorder or any mental or behavioral health condition that co-occurred with substance use disorder, and home was already an eligible originating site on a permanent basis before COVID. In the meantime, even regardless of the public health emergency making home an eligible originating site for all telehealth under Medicare, we've also had the Consolidated Appropriations Act, which made home an eligible originating site for the evaluation, the diagnosis, and the treatment for all mental and behavioral health conditions, regardless of whether they co-occur with substance use disorder. So when the public health emergency ends, and when we have to revert back to the statutory restrictions of eligible originating sites for telehealth under the Medicare program, this has already, through the Consolidated Appropriations Act, been incorporated into the Social Security Act as an eligible originating site for patients with mental and behavioral health conditions. So that piece of this act has sort of already been taken care of and has been enacted through other means. So we continue to see rural health clinics, FQHCs, added as originating sites regardless of geographic area. That particular provision actually really wouldn't be necessary if we waive the geographic restrictions for all telehealth, period, but that was spelled out in this particular bill. You notice again the trend that it would make RHCs and FQHCs permanently eligible as distant sites. This hasn't been enacted, but what it tells me when we're seeing that over and over is that that's a provision that is of interest to a lot of lawmakers, legislatures in Congress, that I think that's an indication of what we may see in the relatively near future in terms of change in telehealth policy at the federal level. And then would also allow the hospice certification and recertification to be done as telehealth versus an actual physically in-person visit. But this particular piece of legislation, again, doesn't look like that's going to move forward and be enacted. It's just an indication of where I think the policy is headed in some form of, Robert and I have talked before about some kind of financial bill, these provisions getting wrapped up into a piece of financial legislation.
And Rochelle, before we hop to the next slide, we've got a question. Are they proposing to eliminate the 6-month face-to-face for mental health patients at home?
So that's a great question. And so Bob, what Bob's referring to is in the Consolidated Appropriations Act, there is an interesting and something I can't really explain why it was put into the Consolidated Appropriations Act that is different from the Support Act. So the Support Act that is already in place pre-COVID, allowing telehealth services to be delivered to a patient at home under the Medicare program for the evaluation, diagnosis, and treatment of substance use disorder or mental health conditions co-occurring with substance use disorder, but the SUD is kind of a core component of that, does not have a requirement by the statute to have an initiating in-person visit. But when the Consolidated Appropriations Act was passed, that made that same telehealth service available to patients at home under the Medicare program, even absent a substance use disorder, but for any mental and behavioral health condition. Part of that act by law requires an initiating visit within it was initially 12 months and I think they reduced it down to 6 months, if I remember correctly, of the telehealth service, meaning a provider in the group that will eventually be rendering the telehealth service to a patient at home for a mental or behavioral health condition had to have an in-person initiating visit. So right now, Bob, that's not part of these bills that are currently being proposed, but it certainly could be something that gets removed. And I think there is a bill that hasn't had a lot of progress. I'll check on that when we're going through the slides that would remove that. Now that requirement for the initiating in-person visit only goes into effect when the public health emergency ends. because right now we can deliver all telehealth services to patients at home under the Medicare program. And that in-person visit requirement only goes into effect when that flexibility goes away, which is when the federal public health emergency ends. Would PCP face-to-face exam count if not part of the mental health group? That's also a great question that they addressed in the Medicare final rule for 2022. So who has to deliver that initial in-person visit prior to a provider delivering a telehealth service for mental or behavioral health conditions for patients at home? When that requirement goes into effect, which is only after the public health emergency ends, and only if we don't have legislation that removes that requirement at some point in the future. The way the statute is written in the Consolidated Appropriations Act is it says the provider has to have an in-person visit within I think it says prior to, and so prior to the telehealth visit, and Medicare had to establish what that time frame is. They proposed 12 months. They reduced it to within 6 months of the telehealth visit, but they also then had to address who can deliver that in-person visit requirement. And in the discussion in the final rule, it said, even though the statute says the provider, which suggests an intent that it be the exact same individual, Medicare discussed how a lot of times for billing purposes, they consider a provider in the same group practice of the exact same specialty to be treated as the same professional for billing purposes. And that was the definition that they adopted for that in-person visit requirement. So same provider, same special, or excuse me, not same provider, same group practice and same specialty delivering the in-person visit within 6 months of the eventual telehealth visit. But again, I want to emphasize that's only when the public health emergency ends that in-person visit requirement is even triggered. So under the Telemental Health Expansion Act, it would expand the provisions of the Support Act for telehealth to certain other mental health services. This particular bill was discharged. However, it has already been taken care of and incorporated by statute through the Consolidated Appropriations Act and the exact provisions that Bob was talking about through the 2022 Medicare final rule. So a very similar bill that was introduced in June of last year, it's been read twice, referred to the Committee on Finance, but since then hasn't advanced any further. This is one, there you go, Bob. It would remove, if enacted, that statutory requirement for the in-person non-telehealth visit 6 months before the telemental health service. So Bob, you and others that may be providing, may be interested in providing telehealth for mental and behavioral health conditions to individuals who are at home after the public health emergency ends, this may be a bill that you want to follow this link and find out who the bill sponsors are. Contact your own representative in Congress and let them know and encourage them to support this bill, because that's an important provision that would bring these telehealth services for mental and behavioral health conditions sort of in parity with the Support Act counterpart for telehealth services that can be mental and behavioral telehealth. They just happen to coincide or co-occur with substance use disorder. Now, the other thing that I think is important about the 6-month in-person visit requirement that is only triggered after the public health emergency ends is that another piece of legislation that's going to be very important, or aspect of legislation that will be very important to if and whether that 6-month in-person visit requirement is ever triggered, is also watching for legislation that may, like that first one I showed, simply define originating site as wherever the patient is located. Essentially, not restricting the patient's location in any way, as being at home, as being in a certain type of healthcare facility, or defining home as an eligible originating site on a permanent basis, even after the public health emergency happens. If we have a piece of legislation that does that, that 6-month in-person visit requirement also would not be triggered. And the reason is that 6-month in-person visit requirement before a telehealth visit for a mental or behavioral health condition is only if we are having to rely on the flexibilities of the Consolidated Appropriations Act to deliver that telehealth service. So the flexibilities that would make that possible is that the Consolidated Appropriations Act would allow us to deliver that telehealth service to a patient who is at home and who may not be in a rural geographic area. If we can deliver that mental behavioral telehealth service without relying on the Consolidated Appropriations Act flexibilities, then that 6-month in-person visit requirement is never triggered. So we also want to be watching not only for this particular piece of legislation that would make it very clear under no circumstances whatsoever would that 6-month in-person visit requirement ever be necessary after the public health emergency ends, but also if any originating site is eligible for a telehealth service or home is permanently available as an eligible originating site. And if that happens before the public health emergency ends, that 6-month in-person visit requirement won't be triggered. That's a lot of ifs and contingencies to make that a little bit more complicated, but we'll certainly keep an eye on that and keep everyone updated on the impact of any federal legislation and what that may mean for that 6-month in-person visit requirement that's been such a sticking point. The other thing to consider is the 6-month requirement is not set by statute. That was decided on by Medicare. One of the things that was discussed as a possibility in the final rule for 2022 is the way the statute is written under the Consolidation Appropriations Act is that in-person visit just has to happen. And I forget the exact language. It's something like that the secretary would establish the frequency or the duration when that in-person visit requirement has to occur. So there could be options that we could submit as requests or proposals when the proposed rule comes out this summer for next year, giving the provider discretion to waive that in-person visit requirement in certain circumstances. So we saw that in ongoing in-person visit requirements every 6 months or every 12 months that could be waived under the provider's discretion. So that could be something that could be proposed to Medicare with respect to that initial in-person visit requirement that if in the provider's discretion that wasn't necessary, maybe that could be a flexibility also. So there are a lot of possible policy changes that could give extra flexibility there. We just need to respond to the proposed rule and submit those comments if you have them, and work with your representatives to support that particular act that would explicitly remove that requirement if that's something that you would support. The Telehealth Modernization Act is another one that was introduced just last year, so it's a little bit newer. It did advance to this Committee on Finance at the federal level last February, but there hasn't been significant activity on this particular act since that time, or I should say this bill since that time. This would also remove on a permanent basis all originating site restrictions, meaning it's not just clarifying that the home could be an eligible originating site on a permanent basis. It's just saying wherever the patient is located, we're going to define that as an eligible originating site. So the grocery store, the library, the parking lot, the coffee shop could all be eligible originating sites because we're not restricting that in any way if this act were passed, if this bill were passed, I should say. It would, rather than in a statutory manner under the Social Security Act, prescribe which types of healthcare professionals or entities qualify as distant site professionals, it would then give the Department of Health and Human Services the authority to define distance site professionals on a regulatory basis rather than having Congress define eligible distance site professionals, would not mandate any particular professionals be included or excluded in that list. The other thing that this act would do is take all of those services that have been added on a temporary basis under Category 3 during the public health emergency that either end the day the PHE ends or continue through December 31st, 2023, it would retain those services as permanent telehealth services if this act were passed. Protecting access to COVID to telehealth, not access to COVID, access to telehealth post-COVID is another bill that was first introduced last year, advanced slightly in February, but then no further significant activity after February of 21. It would make permanent changes to the Social Security Act for telehealth, as many of these would. This one is focused on the geographic restrictions. So right now, where outside of the COVID flexibilities, we have to be in a rural geographic area, and there's a really particular definition of what that means. It would remove geographic restrictions entirely. So whether you're in rural Kansas, rural Missouri, rural Oklahoma, or whether you're in a metropolitan area on a permanent basis, could receive telehealth services that are paid by Medicare, also regardless of the diagnosis. So the substance use disorder, the mental and behavioral health flexibilities that have been like limited carve outs for that geographic area, it's going to be regardless of the patient's condition. This would add home as an eligible originating site, but would still retain all other eligible originating site restrictions, but would give the Secretary of Health and Human Services the flexibility to add, redefine, or recharacterize those eligible originating sites. So it's saying the home and all other eligible originating sites we typically have outside of the public health emergency are explicitly at a minimum included, but the Secretary could then add or clarify other eligible originating sites. So this is the third time now that we're seeing FQHCs and RHCs would be added as eligible distance sites. So I definitely see that provision as something that's likely to be included in whatever telehealth expansion ends up getting passed, if any. That seems to be a really common denominator that's likely to be included. Protecting rural telehealth, as you can imagine, is focused on rural access. Interestingly, would waive the geographic restriction, which actually increases the access outside rural areas and not necessarily within rural areas, but would add home as an eligible originating site, which is a piece that would increase access both in rural and non-rural areas. RHCs and FQHCs, we're seeing that again. It would expand coverage for asynchronous telehealth services as well. So right now, with very, very limited exception that I don't think applies likely to anybody that's on this call, it's just Alaska and Hawaii. Asynchronous, meaning it's not real-time communication, store and forward, and also with limited exceptions for things like video recordings and reviewing photos that have their own separate benefit that aren't considered telehealth, could then be classified and covered as telehealth services. So this one was introduced a little bit later in the year in June, has been read twice and referred to the Committee on Finance, but no significant activity since last summer. Now, audio-only coverage has been a significant topic of conversation and its availability after the public health emergency ends. We saw that in the Consolidated Appropriations Act that makes coverage for mental and behavioral telehealth to patients who are at home
Rochelle, I believe your audio is freezing right now, or at least it's freezing for me.
Yes, it has frozen.
She's locked up on my screen.
Yeah, well, hopefully she'll be able to call back in just a second. So let's hopefully either by phone or we'll see what happens. Try to reach out to her so we know sometimes you don't know when you're frozen up. So actually, it looks like she knows. Hopefully, she'll come back in or call back in.
Okay. Can you hear me now, guys?
Yes, we can hear you fine. And
All right, perfect.
You discovered that quickly. Good for you. Sometimes I talk and talk and talk and never realize it.
That's all right. Do you have the screen? Are you able to see the screen again?
We are Permanency for Audio Only Telehealth Act.
Perfect. All right. Well, where did I leave off? That was actually a good time for my audio to freeze because the kids came inside from the snow and there was a little bit of background noise there. I guess I can start over. I'll just start over on this slide where coverage for audio only services has been a really significant topic of conversation and concern and interest in continuing the coverage and the accessibility of audio only services when the public health emergency ends. And so this act, again, relatively new, it was just introduced in May of last year and has been referred on to committee, would permanently make audio only available as a modality for telehealth services under the Medicare program. Now, unlike originating site rules and distance site professional and geographic area restrictions, those are all set by statute where we have to have a literal act of Congress to make permanent changes to those provisions and those restrictions. What Health and Human Services has the flexibility to do on a regulatory basis is define the modalities that are allowed for telehealth services. What it says under the statute is a live, interactive, two-way communication, but it doesn't define audio visual within the Social Security Act. So this act would define by statute and allow audio only equipment for the provision of telehealth services for evaluation and management services, certain mental and behavioral health services, substance use disorder services, and sort of interestingly give Health and Human Services to add others by audio only, which is actually authority that Health and Human Services already has to define the modality of coverage for telehealth services, but it would make that permanent. I'm going to talk in just a little bit too about some provisions in Missouri and questions as December 31st, 2021, when the state emergency order ended, and how that impacts audio only in Missouri, as well as a new bill in Kansas that has popped up that affects the availability of audio only services. So we've talked a couple of times about a new place of service code for telehealth services. This is not yet for the Medicare program. Medicare creates and maintains the list of place of service codes. And so while Medicare created this new place of service 10, Medicare is not requesting or requiring its use. However, providers and payers, because the place of service codes that Medicare publishes is a HIPAA mandated transaction set. All payers have to be able to use it and accept it, and all providers have to be ready to use it and accept it when required by payers. Effective for dates of service January 1st, 2022, but the payers don't actually have to be able to accept it until April 4th, retroactive to dates of service January 1st. And that doesn't mean that providers have to use place of service 10 code yet, but they have to be able to use it if a payer requires it under certain payer policies. I've not seen yet, at least in our area, any payer policies that have been reviewed and revised to mandate the use of that code. But I think that's something we're going to be on the lookout for as policies change or potentially wind down, or use of telehealth in the patient's home becomes a focus of policy at the state level. So now I want to switch gears just a little bit and talk about state-specific pieces of legislation and changes that are going on. So early January, the first week of January, before the legislature was back in session, Governor Kelly issued a brief 15-day disaster proclamation and had 2 executive orders that went along with it until the legislature could come back into session and address what at the beginning of January was a significant surge in COVID cases that was kind of overloading hospital and health systems. So what that disaster proclamation did was give the governor the ability to issue executive orders on a temporary basis. And she did issue 2 executive orders that relaxed or removed the supervision, delegation requirements or related requirements for healthcare providers. So physician assistants, the supervising physician requirements, APRNs and the collaborative practice agreement requirements were waived during that period. It also allowed students to provide services within a healthcare facility consistent with their education and training, and professionals that are licensed and in good standing in any other state could provide care in Kansas under that first executive order. And then Executive Order 2202 had similar provisions specific to individuals that are licensed under the Kansas Department of Aging and Disability Services. Now, in the meantime, we've got our Kansas Telemedicine Act. So this is has been still in effect during the public health emergency, but there is right now a new bill in Kansas that would affect several provisions of the Telemedicine Act. It's been referred to the Committee on Health and Human Services for the state January 25th. So this is a pretty new bill that has, I think, fairly significant potential ramifications. The first of those is that it would, in defining the distant site from which telehealth is delivered, right? So this is where your physician or healthcare professional is located, that would include an unlicensed or a private location. So rather than defining the distant site as a place like a hospital where the distant site professional is rendering a service, that would give flexibility for distant site professionals to provide telehealth from home, right? An unlicensed location. It's not a community mental health center, hospital, ASC, that type of licensed healthcare facility. It would also create a distinction between healthcare providers that have a permanent license to practice in the state of Kansas versus something that a new definition called an interstate telehealth practitioner. And an interstate telehealth practitioner has this limited telehealth license in the state of Kansas that's now available on a permanent basis, but the individual practitioner doesn't have a physical practice location in the state of Kansas. And the distinction between an in-state practitioner who does have a physical practice location and an interstate telehealth practitioner who does not have a physical practice location under this bill would have an impact on whether that professional can render certain services via telehealth and audio only and with or without a pre-existing provider-patient relationship. The definition of telehealth would specifically include remote patient monitoring under this bill, but I'll put an asterisk on that because it doesn't then define what remote patient monitoring is. And so for coding purposes, we make a distinction between remote patient monitoring and remote therapeutic monitoring. So one of the things that's not clear to me in that by adding remote patient monitoring as part of the definition of telehealth is whether that would include the new codes that we saw in 2022 added that are covered by Medicare that are remote therapeutic monitoring, which means they're more subjective patient input, and it's not necessarily a device that automatically transmits results from the patient's monitoring device directly to the provider. Many of the references in the Telemedicine Act that currently use the word physician would be changed to more broadly use the term provider. So expanding, which type of professionals are covered under the Telemedicine Act. And so this is where the distinction between in-state, a provider who has a physical practice location in Kansas versus one who does not, really comes into effect. And in-state providers could use audio only for established patients, but only if audio-visual is not reasonably available. The way I'm reading this bill, this to me seems to actually restrict the availability of audio-only services as opposed to expand the availability of audio-only services, because right now, the way that telehealth is defined includes includes audio-only services, and also explains that the provider-patient relationship can be established via telehealth as long as it's consistent with standard practice and the standard of care. So this, to me, suggests, it doesn't say that audio only can or cannot be used for new patients, but by explicitly saying it can be used for established patients and only when audio visual is not available, suggests to me that the opposite may not be true. Suggests that if passed, audio only is not available for new patients, and not necessarily available to establish the provider-patient relationship, and also doesn't specify that audio only is an option for interstate telehealth practitioners. So that piece really leaves a lot of questions for me on what the intent and what the impact is with respect to the availability of audio-only services in Kansas if this bill were to be passed. It also says that health plans cannot require the use of any specific information technology by an in-state practitioner, which suggests that health plans could possibly limit or restrict the type of technology by interstate telehealth practitioners. This is significant to me because I think this has implications for practices and groups that use, the national telehealth companies, where that billing professional may not have a physical practice location in the state of Kansas, and that health plans could then require the use of certain telehealth technology for interstate telehealth practitioners like those national telehealth companies. I think it also has implications on the way the contractual arrangements with interstate telehealth practitioners are made and who the billing provider is in those contractual arrangements: the interstate practitioner, the interstate, the national telehealth company, or the local in-state practitioner with a physical location in the state of Kansas.
And Rochelle, we do have a comment in the chat that
sure.
I believe is from the previous slide. It says Kansas Blue Cross Blue Shield is indicating place of service 02 if a patient is in their home, and then place of service 10 if in any other location. Have you seen that, or?
No, but what I can do is make a note. Let me jot this down just so I don't forget to send these follow-up items. I'm going to send the link to the CMS telehealth, and I will try to pull that policy from Blue Cross Blue Shield of Kansas and send that out as well.
And then while we're paused, we've got another question. It's from Carol Gilmore. Are we to assume that all the technology applications are HIPAA compliant?
Oh, great question. And no. Let me forward to the slide that we're on here. So are we to assume that all of the telehealth platforms and technologies are HIPAA compliant? No. And that is a common, I think, misconception of some of the guidance that has been released during the public health emergency. There was a limited waiver of the Office for Civil Rights Enforcement discretion with respect to the use of certain consumer applications that would be used to deliver telehealth services. HIPAA is still active and it's still in effect. The privacy rules are still in effect and the security rules are still in effect. but the Office for Civil Rights would not impose penalties for potential security issues on certain consumer-facing applications during the public health emergency. But the Office for Civil Rights is not the only agency that is eligible to enforce HIPAA. So state attorney generals can also enforce HIPAA and have not, to my knowledge, issued a similar waiver of their enforcement discretion to impose enforcement actions if there was a breach for using consumer applications. And so what that means by consumer applications, they still have to be private. So it can't be like FaceTime Live or YouTube, right? Obviously, where that session is broadcast to others besides the individuals. But FaceTime on an iPhone, right? It's between two individuals, but it's not necessarily intended to be a HIPAA compliant communication. That's what that Office for Civil Rights limited waiver of enforcement discretion said. However, for healthcare providers, I would still strongly encourage you, as you are contracting with vendors for telehealth services, to do the same type of security due diligence that you would perform for other security IT type vendors, and making sure that their platform is HIPAA compliant, and making sure that the product or the platform that you're purchasing and contracting with is a level, or the subscription that is intended to be used for healthcare services. Using Zoom that we're on for an example, they have a platform, they have a subscription that is intended for healthcare use that has additional security measures that the general free Zoom subscription that anyone can sign up for does not necessarily have. So another interesting provision here, health plans could not impose higher cost sharing for in-state practitioners. But if this bill was passed, could potentially or hypothetically impose higher cost sharing if telehealth is provided by interstate telehealth practitioners, those who don't have a physical practice location in Kansas. So under Kansas Medicaid, the last that I've checked, all of the policy bulletins that increased the access to telehealth during the public health emergency and even during the state emergency declaration, they still have language that says they are in effect until rescinded, and I cannot find any policy or indication that those have been rescinded yet. So that's something we have to continually watch for notice that those policies are going to be withdrawn, and hopefully we'll get some advance notice before that happens. Now in Missouri, the initial COVID emergency declaration ended mid last year and was replaced with an emergency that was related to healthcare staffing shortages. And that emergency declaration expired December 31st of 2021. The significance of that is it left a lot of questions about the availability of audio only services that were available as a result of that declaration, provider licensure, particularly providers licensed in other states who are rendering telehealth services to individuals within the state of Missouri, and whether and how the provider-patient relationship could be established via telemedicine. So one of the particular statutes that was a focus of the flexibilities during that staffing shortage emergency declaration was a paragraph under RSMO 191.1146, and it said telehealth, the technology utilized for telehealth, or let me start over from the beginning, to establish a provider-patient relationship through telemedicine, the technology has to be established or sufficient to establish a diagnosis as though the interview and exam has been performed in person. And because that particular provision was waived as part of the emergency declaration, there was a lot of question about what impact does it have that language is now operative and in effect again as of January 1, 2022. There was a memo put out from the State Department of Health and Human Services to all Missouri hospitals. I it doesn't say that this is limited to hospitals because the state statute applies to all professionals. But this went out to hospitals saying that the provider-patient relationship can be established through a physical exam that is conducted either in person or through telemedicine. So that it kind of clarifying that physical exam component doesn't have to be an in-person physical exam. You could, for example, coach the patient through taking heart rate, respiratory rate. You could do an exam of cognitive status, alert, orientation, several objective findings, as long as it's consistent with the standard of care through telemedicine. And this is published on the Department of Health and Human Services in their hot topic bulletins on their website. January 12th of 22 explains that the requirements of the provider-patient relationship that were waived are going to continue until further notice, until CMS approval is granted to rescind that. However, 2 days after this was published, we got the letter from the agency that actually says that provider-patient relationship can be established through telemedicine as well as in person. So I have not seen anything as of late last night changing the flexibilities under the Missouri Medicaid program, so that will continue to be in effect until further notice. No, in Oklahoma, there was a payment parity law passed last year, went into effect, I should say, January 1st of this year, that adds some definitions to telehealth services for Oklahoma, meaning mobile health, something where a patient or health information through internet or wireless devices to obtain or create specialized health information is part of the definition of mobile health that's part of the telehealth coverage in Oklahoma. What I like about the way Oklahoma has defined mobile health is that seems to encompass the remote RTM service. I'm totally blanking on the term. Remote patient monitoring, as well as RTM services, and originating, say, where the patient's located that may include, but is not limited to, home, workplace, or school. So essentially, any place where the patient's located is an eligible originating site in Oklahoma. And then defining remote patient monitoring services more specifically, with or without a digital upload, also suggesting that RTM services may be encompassed in that definition. In the Oklahoma Act that went into effect January 1st, there's also some specific provisions about the way health plans have to cover telehealth services, so they can't exclude coverage just because it's provided through telemedicine, but they may limit coverage consistent with coding and clinical standards, meaning the standard care. If a service cannot be provided via telemedicine, it could potentially be excluded from coverage on that basis. There's payment parity. That was really a focus of this act that went into effect January 1st. So for dates of service on or after January 1st, payers that are covering telehealth have to pay at the same rate of reimbursement, which, by the way, is also the policy of Missouri Medicaid's program. They've clarified they don't have a separate fee schedule for telehealth. It's paid at the same rate as in-person services as well. So I know I've gone a few minutes over time. I'll pause here, and I know I've got a couple takeaways to pull the Blue Cross Blue Shield of Kansas policy. And I saw someone mentioned that it was announced during a meeting last week. I'll pull the CMS link for telehealth services for 2022 as well.
Sounds like there are a lot of great materials related to this. We'll send those out with the PowerPoint. And as always, thank Rochelle for all of the amazing work she's done. And Christy, I don't know if we have any final announcements.
Yes, so we will send the recording follow-up materials as soon as we can. If you haven't re-enrolled in the webinars, we need you to just sign up one time. I will put the link in the chat here, and we'll also put it in the email. And then we hope you can join us for the next webinar on February 23rd at noon, where we will discuss telehealth and therapy disciplines. Thanks, everyone.